bagels, dogs.
Yeah, Austin take his time.
Are they enjoying Simon?
They are enjoying it.
Do we have the good doc coming on or not?
I was listening to it, Nadia, but I thought I'd also read.
Ms. Sawyer, do we have the good doc coming on or not?
He verified it with Mr. Gable last night, that he had the link and that he would be on.
There, is that him coming on?
That is him.
Hi, Doc. Can you hear me?
Hello? Yes, sir. Yes, Your Honor.
Okay. We're getting jurors organized. Just chill there for a minute.
Okay. Okay.
I'm going to go on video just for a minute and let him know I'm here. Dr. Hagris,
I'll be asking your questions.
Oops,
Hang on.
You gotta mute your mic.
Yeah, I'll be asking your questions, but I'm going to put my video off so they only see you, okay?
Oh, okay.
And I'll also be sharing the screen to show you exhibits.
Got
Okay?
So while we're off moving,
Yes.
this is what you can see.
Okay.
So whatever camera is on, what you
Okay.
Can you see the overview of the courtroom? Now you'd see a picture of me.
Yeah.
Okay. We're just making sure the technical's working.
Let me do one more thing. Let me make sure if I share, he can see it. Hang on. Oh, crap. Where'd it go? I had it up. Dr. Hagris, can you see that?
Yes.
Okay. It's not.
Between batteries and puppies.
Judge, when Sam comes back, we may want to resolve a potential issue.
Okay? Let's chill. She's walking in.
Excuse me, sorry.
But there's still plenty.
Jose, he's got all of them. Yep, he's got a copy of everything.
They're not the entire, what's relevant to now? When I printed out what's relevant to him on each of those pages, I mean, not use all of them, but I printed out what was relevant, so you can have those instead of having to. Yeah. Yeah.
Okay, we're on the record. All counsel are present along with the defendant. There's some preliminary matters we need to deal with. Mr. Baez, you had a preliminary matter?
Yes, I just wanted to make sure that the state is not anticipating calling Dr. Hagris as an expert witness. My understanding is, if anything, he's a fact witness, and to elicit opinions on specific matters, we've not been given any notice of that.
Your Honor, he is going to be here as a factual witness to talk about some hospital policies that he's familiar with. We're not intending to use him as an expert witness. He did have involvement with some of our victims. We're going to talk about his involvement. We did not provide an expert report on him because he's not being treated as an expert, other than the fact he's a treating physician, which may be a good time to raise the fact that we still don't have expert reports from the defense.
We forwarded them to you already, right?
We haven't gotten.
Last night, yes.
We didn't get any.
Okay, well, that's a logistic issue you all can deal with on the break. Okay. Anything else for the record?
No, that's it. That's all I wanted to make sure of.
Okay. Let's bring him. Is there a problem?
No.
Are they still playing with the puppy?
No. So,
Okay.
Susan was in the background and,
What did Susan want?
well, I don't know. She's not.
Doc, I've got to do some housekeeping first, and we'll be right with you, okay? Did you hear me, doctor?
Yes, sir. Yes.
I gotta do a little housekeeping with the jury and then I'll be right with you, okay?
Okay, okay, okay.
All rise. Thank you. Please be seated.
Good morning, ladies and gentlemen. Sorry to interrupt your wonderful morning so far from what I hear. You'll notice the plexiglass is down between the second row. They had problems installing the second ones because of the split, so you can actually reach out and touch the person in front of you if you want. The plexiglass will be up, the 3/4 glass will be up Monday supposedly. So I was just letting you know that. Our first witness today we're doing via Zoom, okay? You're to treat him as if he were live here on the stand, okay? We've got it set up with the technology. Technology is a wonderful thing. We worked our way through all the things. We should be in good shape. Okay, so with that, doctor, raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
Yes, Your Honor.
Okay. Ms. Sawyer?
Thank you, Your Honor. Doctor, could you please state your full name and spell both your first and your last name for us?
My full name is Saad Ahmed Hagras. My first name is Saad, S-A-A-D. Last name Hagras, H-A-G-R-A-S.
And sir, you're testifying via Zoom because you had a family emergency and are out of town because of that. Is that correct?
Correct.
Dr. Hagras, where are you employed?
Where what, I'm sorry?
Where are you employed? Where do you work?
I'm employed in Mount Carmel system through Mount Carmel Medical Group. And I start working in Mount Carmel West, and right now I'm in Mount Carmel Grove City.
And when did you first start working at Mount Carmel West?
June 2013.
And what is your job position with Mount Carmel?
I'm an acute care physician, acute critical care physician. I work nights from 7 p. to 7:30 a.m.
And have you always worked the night shift?
Yes, ma'am.
And let's talk a little bit about your background. What type of education do you have to hold your current position?
I finished 6 years of medical college in Ain Shams University in Cairo. Then I did my exams and I came over to US and I did my residency, 3 years internal medicine in University of Maryland's East Campus in Baltimore, Maryland.
And when did you receive your licensure, sir?
I received my license in Ohio.
And what year?
It's 2009.
And do you have any type of continuing education requirements in order to maintain that licensure?
Yes, I do.
And what are those, sir?
It's online courses and some seminars.
And has your licensure remained in effect in Ohio since 2009?
Yes, ma'am.
Are you board certified in any type of medicine?
Yeah, I'm board certified in internal medicine.
And how long have you been board certified, sir?
Since 2012.
Now, you indicated you worked the night shift with Mount Carmel. Are you assigned to any specific department?
Only ICU.
And have you always been assigned to the ICU?
Yes, ma'am.
Can you tell us a little bit about what type of training, on-the-job training or orientation did you receive when you first started at Mount Carmel Medical Center West?
When I came, I had only like a few hours orientation with a doctor. His name is Shiraz, or something like that. Yeah, I don't remember exactly, but he was a locum, and he used to cover ICU nights. So he gave me an orientation for like 3-4 hours. He showed me the ICU, the layout, introduced me to the charge nurses, and showed me the EMR system. And I had also, before that, I had 2-3 hours IT training for the EMR,
Okay.
electronic medical record.
Okay, that was what I was going to ask next, so thank you, sir. Did you receive any type of training from Mount Carmel regarding, in this type of circumstance, or to use this type of procedures or medication?
No, ma'am.
Okay. Did they show you anything or refer you to anything that would help you reach decisions, say if you were doing a palliative care withdrawal?
Well, they showed me the main website of the Trinity, and there's a link for like health stream, link for hospital policy and procedure, link for medication interactions.
Dr. Hagris,
Hey,
I'm going
hold
to stop
on
you
one
for a
second,
second.
Doctor.
We have an objection.
It's non-responsive.
Okay,
She asked him
overruled.
if he was trained, he just started to describe the system.
I understand, I overruled it.
Okay, go ahead. You were indicating they showed you the different
Objection,
systems.
leading, and that's not what he said.
Okay. We're gonna take it back. Technically, she's catching up on the question, overruled. He was in the middle of his question. You can ask him to continue on, I would guess.
Please continue on, Dr. Hagris. If you need me to repeat the question, I will do so.
No, they showed me this like main website that has multiple links for like, if I need up to date, if I need the policy procedure of the hospital, if I need medication interaction, if I need a physician, links, if I want to get like physician cell phone, if I want to put a voice. So this showed me this multiple links,
Okay. And in the years you've been practicing at Mount Carmel, have you utilized those links?
Sometimes.
Okay. What circumstances might you utilize those links for?
Well, I always like try to find, like when I try to call a physician overnight, I can go to the system and find who is on call so I can get hold of him. Sometimes if I want to put a voice, I remember I put a voice in 2013. So yeah, I utilize it sometimes, yeah.
Okay. Now you indicated a voice. What is a voice? What does that mean to us?
A voice, it's when I see an error, medication error, I put a voice for this. It's like a complaint report.
Can you repeat that? Our court reporter, it glitched a little bit, so our
Okay.
court reporter's trying to catch what you said.
It's like a complaint report. If I have a complaint regarding an error of medication, I can put it in. So this is the link, I will use it.
Okay. Now, as a physician in the ICU, how would you obtain medication for a patient?
Well, if I need to give a medicine to a patient, there's two routes. There's a stat and routine. So I need to go to the EMR, electronic medical records, and place an order as a stat or routine, and the nurse will call the pharmacy if it's stat to get it stat, and routine just will come on its time.
And so you place the order, and who actually pulls the medication?
The nurse.
Do you know where the
It's
nurse?
either,
I'm sorry, go ahead.
so it's either the medicine will be delivered to her, or she can pull it out from the Pyxis after she talked to the pharmacist.
Okay, so what is the Pyxis machine?
Pyxis machine is like a medicine closet, you know. It's just it has drawer. It's a cooled, so the nurse can go in and put her ID and get the medication out.
Okay. Are you aware of the override system that can be used with the Pyxis machine?
Yes, ma'am.
Tell me about that.
Well, my knowledge is limited that it only existed, but I don't know how it works really.
Okay, that's
I
fair.
know the nurse only the one that can do that, but I never got involved in any override really process.
What if there's a code in the ICU? How do you handle the obtaining of medication at that point?
We have a crash card. It's a blue card. You know, we have it, multiple ones in the ICU, and we pull it, and we have all kind of like, you know, cardiac medications in these cards. So like epinephrine, atropine, dextrose, this kind of like cardiac medication. Then I start resuscitating the patient. Also, the pharmacist will come to the code blue, and he will have his own cards, and he will provide us also with, like, you know, these medication.
So if there's a code, you're not using the Pyxis machine at all?
No, ma'am. No.
Okay. Dr. Hagris, are you familiar with William Husel?
Yes, ma'am. Yes.
How do you know William Husel?
Dr. Husel, he started August 2013, and he had an orientation with me for like 3-4 hours, and I showed him the same, like, you know, what I had, like, you know, the layouts. I introduced him to the nurses, showed him the AMR, our on-call like room, our codes, the code combination for the room. And then he started with like as alternating shifts with me. It's about like 1 week on, 1 week off. Then I also met with him in multiple meetings with Dr. Swanner and Dr. Rolliston.
Did the two of you have the capability of communicating in between shifts if you needed to?
Dr. Husel, he didn't have a cell phone, so he had an email, and he was really good about responding to his email. So every time I send him an email, he would respond to me in like 3-4 hours.
Did Dr. Husel ever ask you about palliative withdrawals or palliative ventilator extubations?
No, we never talked about any patient management. Our talk was about coverage, because I used to ask him like to cover me when I go to Egypt, when I went to get married, and he was so nice to cover me all these, like, you know, times. Plus, our talk was also about our contract renewal, but I don't recall at all that we talked about any patient management.
Okay. Dr. Hagris, during the time you've been with Mount Carmel West in the ICU, had you ever had the opportunity to perform a palliative withdrawal or a ventilator extubation that was palliative?
I'm sorry, say it again?
Sure.
To what?
During the time period that you were employed with Mount Carmel West as an ICU doctor, did you ever perform a palliative withdrawal?
Yes, ma'am.
Tell us what you would do in that type of circumstance.
Well, the most common scenario in my practice is a patient has been in ICU.
Hang on, there's an objection, sir.
Relevance, and this is the issue that we discussed before.
Okay, I'll permit it.
Go ahead, Dr. Hagris, you can answer the question.
Okay, the most common scenario in my practice is a patient that has been in the ICU for like sometime in ICU, days or weeks, and there was an ongoing discussion with the family, and the patient, like it's either the patient declines in my shift, or the decision already made before my shift, but the family gathers in my shift and they decide, okay, we are ready, and I am the one on call, so I go in and I confirm that we are on the same page, and I change his code status to do not resuscitate comfort care, and I explain to the family the process of the extubation, that I'm going to stop all the infusion 30 minutes before taking the tube out. I'm going to give a dose of morphine and Versed 10 minutes before taking the tube out. And after taking the tube out, he will have a comfort oxygen. Then after that, every 15 minutes, he will get morphine and Versed till he passes. And during this also discussion, the nurse will be here. I offer also a chaplain support, and like after he passes, I will come back and pronounce him.
Okay, so just a few questions off of what you just told us. You said you would order a Dnrcc. First off, what is a
Yes.
Dnrcc?
It's a do not resuscitate comfort care.
Okay.
Do not resuscitate comfort care, and this is like when I perform any palliative withdrawal, I do that. So this means I'm not going to perform any line of treatments. I'm just comforting the patient. So I'm taking the tube out and give him medication and some oxygen, and this is what's Dnrcc.
Okay. And you said you place you order it. How do you place that order?
Well, there's an order set for palliative ventilator withdrawal, and there's a check box that I can change it to Dnrcc. There's other check box. If I remember, it's to take the tube out. Check box to contact loop organ donation agent. So it's part of the order set.
Okay. And you said you go in and you check it. Is that on what you call the EMR, the electronic medical
Yes.
record?
Yes, ma'am.
So that will physically show up as a order in the medical record?
Yes, ma'am.
Okay. And
Yes,
you
ma'am.
referred to an order set, sir.
Yes.
All right. Jose, this will be the first one for the order set that I handed you. That's from 12/7/10 to 8/17/16. All right. Sir, I'm going to show you in a second, as soon as I get to the right screen, what we have marked as States Exhibit 17A, as soon as it pops up there. Can you identify this for us?
Yeah, this is it's date 12/7/2010. Okay, and this is revised terminal ventilator withdrawal plan of care. Okay, yeah, this is what I'm using to communicate order patient withdrawal support.
Okay.
Yeah.
So this is what you called the order set, am I correct?
Yes, ma'am.
All right. And you pointed to the date 12/7/2010. Am I correct? That's where it begins, and then this policy went through August 17th of 2016?
Yes, ma'am.
Where did you access this at Mount Carmel, sir?
This order set?
Yes.
Yes, this is in our electronic medical records.
Okay. All right, and tell us a little bit about what this is exactly and how you would utilize it. And tell me when I need to move the page up so you can see more.
Yeah, this is the beginning of the order set. So if you can scroll down, so I need to check the box, these boxes. So I will check these first three boxes. Okay. So then when I go to the medication, I will
looking it
find
up.
where I can give 10 minutes. Yeah, this one. So so I will check the first box, pharmacy. If patient is on paralytics, I will need to stop that. Then the second box, I will check it, and I will use the 5 or 10 milligram, which is 10 minutes before taking the tube out. And I will check the second box, the third box. Then I will choose, I will check the fourth box. I will use maybe, this is when, okay, so, I will check the third box for the first hour. Then I would choose like maybe 4 milligram every 50 minutes. Then the fourth box, I would check it if the patient survived for more than 1 hour. I will check 4 milligram, and I can choose between morphine and dilaudid, and I always like choose morphine, sometimes dilaudid, but mostly morphine. And then I will scroll down to get to the Versed and Versed injection. This one I will check it, and it's 2 milligram IV, and this is, I will tell the nurse to give it also with the morphine 10 minutes before taking the tube out.
Okay.
And if you can scroll down, if you can scroll down, and okay, then I will check the Ativan. Here it's 1 milligram every 15 minutes after taking the tube. Then I would check the Ativan if he survived more than 1 hour, 1 milligram every 4 hours after first hour if he makes it after 1 hour. Then I'm going to check the atropine for any increased salivary secretions. And I'm going to check the oxygen therapy, and I'm going to specify it's 2-liter oxygen for comfort. Then I would sign up. I would sign with my name, and I'll just put it through. Yeah.
Okay. So all this would show up on the EMR.
Yes, ma'am.
Now you said first that you stopped the paralytics 30 minutes before. Why do you do that, sir?
Well, because I need to assess the patient to see if he is in pain or any air hunger after taking the tube out. So I need to be sure that paralytics are out of his system so I can get an accurate assessment.
All right. And you indicated you usually start with, did I hear 5 milligrams of morphine? Or did I say that incorrectly?
Yes, 5 milligram, 10 minutes before taking the tube out, with 1 milligram of, or 2 milligram Versed also 10 minutes before taking the tube out.
All right. And just so I'm sure I know what you're talking about, Versed is the brand name for midazolam, am I correct?
Correct, ma'am. Yes.
And the Dilaudid is the brand name for hydromorphone.
Correct.
Okay. You mentioned the atropine for secretions. What does that mean to us?
For salivary secretions, some patients, when they take the tube out, they will have a lot of saliva, and this will give them a lot of discomfort. So we give them atropine to dry out these secretions.
The end there says oxygen therapy. Explain to us what you do on that.
It's a nasal cannula. It's a 2-liter nasal cannula. Okay, we put it for the patient for comfort.
Okay. And then you also mentioned extubation. Are these patients on ventilators typically?
Typically, yes.
So what do you, describe to us just briefly, when you say extubation, what are you talking about?
I'm talking about taking the tube out. So patient will get a set of medication 10 minutes before taking the tube out. Then the nurse and the RT will be there. They will deflate the balloon. Then they take the tube out. Then they will put the 2-liter nasal cannula on.
Okay. All right, and we've talked about several medications, morphine, Versed, Dilaudid, Ativan, atropine. Is fentanyl anywhere on this palliative order set?
No, ma'am.
Dr. Hagris, are you familiar with the conversion rate between what would 1 milligram of of morphine be as far as how many micrograms of fentanyl?
1 milligram morphine, it will be equal to, I think, 10 microgram of fentanyl.
All right, so if I go back up here, sir, I'm just going to go back to the first page. So if you're starting, let's even go with 10 milligrams of morphine. See how good you're at math? How much? I'm sorry, go ahead.
I'm sorry, it depends on the patient, you know. When I assess a patient and I see, like, you know, what's his clinical condition, what's his comorbid diseases, what's his age, what's his size, what's his body habitus, what's his tolerance to these medication, I decide which dose I will use.
Okay, so if, let's say you chose 10 milligrams of morphine, what would the conversion be to fentanyl?
Objection.
I understand. I'll permit it.
Thank you. Do you remember the question, Dr. Hagris?
Oh, yes. 10 milligram will be 100 mics of fentanyl.
Okay. Dr. Hagris, you're still at Mount Carmel West. Has this has this order set changed over the course of time you've worked there?
No, not to my recollection, really.
All right.
Not to my recollection.
Did they adopt or at least update the policy to your knowledge?
No, I really don't know.
Are you aware, Dr. Hagris, of, at this time, whether there's a mandatory?
Objection. He just stated he's not aware of any changes.
Haven't resolved the question. Let's put the question on.
Certainly. And Dr. Hagris, don't answer this yet, but I'm going to put the question on the record, okay? Are you aware of whether there is currently a mandatory order set for palliative care withdrawal? And hang on a second before you answer that.
Okay, I'll permit that question.
Okay, Dr. Hagris, you can answer that if you know.
No, ma'am.
Okay.
Not to my knowledge.
Dr. Hagris, have you used that order set throughout the time period you've been with Mount Carmel?
And even before Mount Carmel, in my prior job in Atrium Medical Center, we started with Epic, and I started using order sets. So when I came to Mount Carmel, I had the mentality to use order sets. So when I came, I created all my favorite order sets for all kinds of treatments, including palliative withdrawal.
And can you estimate approximately how many palliative withdrawals you've done during your time with Mount Carmel West?
I don't have an exact number, and it's just hard to estimate, but I would say maybe 15 to 20 ones a year, but it could be really wrong. So I really don't have an accurate number.
Have you always used that order set when you're doing a palliative withdrawal?
Yes, ma'am.
Have you ever had an issue with the patient while using that order set?
No, ma'am. Because the patient will get these medication every 15 minutes.
Okay.
So he will get enough of these medication, and the patient will get assessed every 15 minutes. So if the nurse has any concern, she will call me and I can adjust the dose, but it's rare to happen.
Can you think of what the maximum dosage of morphine you've ever used is in a palliative withdrawal?
Well,
Objection. This is again. Expert opinion.
Okay. Maybe we should sidebar it real quick. Ladies and gentlemen, entertain yourselves.
Dr. Hagris, we're going up to see the judge, so just hang on for a minute, okay? Dr. Hagris?
I'm
sorry.
Yes.
All right, Dr. Hagris, I believe I asked you if you had ever had a problem with a palliative withdrawal patient when you're following that order set.
No, ma'am.
All right, Dr. Hagris, I'm actually going to talk to you now about some of the patients you have treated that our case is involved with. So give me 1 second to switch files. And we're going to start with Ryan Hayes. Let me share a screen. And give it a second to come up. All right, and Dr. Hagris, this is what I have for the record marked as Exhibit 2C. And can you identify off of that the patient we are referring to?
It's Ryan Hayes, and his date of birth is 5/15/77. He was admitted on,
That was what I was going to ask you next. You're ahead of me. Does this document show what date he was admitted to Mount Carmel West?
yeah, he was admitted on the April 2nd, 2017.
And does it show which date he was discharged, sir?
Yeah, he was discharged on the April 4th, 2017.
All right, and I'm going to skip down a second to, it's going to be page 5 of my document, so give me just a second. All right. And Dr. Hagris, I am going to refer you to this page, which I currently have up. Did you have involvement with him on Mr. Hayes on April 2nd of 2017?
Yes, he came to ICU and I saw him and I was a critical care consultation. I was a critical care consultation at this point, yeah.
All right, and tell me what a critical care consultation means to you, please.
Means managing the patient ICU from hemodynamics standpoint, from ventilator standpoint, and managing like all kind of electrolytes abnormalities. If he needs any medication to support his blood pressure, support his heart.
Okay. And you use the word hemodynamic. Tell us what that means, please.
Hemodynamics means blood pressure, heart rate, and oxygenation. So these are all the hemodynamics that are managing these patients in the ICU.
Okay. And I'm going to scroll down the page here a little bit to the next page. Can you tell us why you were seeing Ryan Hayes at this time, as far as what his circumstances were?
Well, the patient presented to our emergency room because of cardiac arrest. He has IV drug abuse history. His sister found him in the bathroom and he was pulseless. So she called EMS that they start resuscitating him, and he got 5 runs of CPR along with medications and shocking. Then he came to our ER. His blood pressure was low, so they started him on a pressor medication called Levofit to bring up his blood pressure, and they give him a bicarbonate, and of course he was intubated. I didn't put this in my note, but I assume he was intubated. So I talked to his sister in the waiting area, and I showed to her what I found in his CAT scan, and she agreed.
Dr. Hagris, I'm going to stop you for a second. There was an objection.
He said, I assume he was intubated. I think we need to make sure.
I think I'm fine with striking that part at the moment. I'm sure we'll get to that as we go further down.
Disregard his assumption.
All right, go ahead. I'm sorry, Dr. Hagris. Go ahead with what else you found at that time.
And the CAT scan of his head, I explained the findings of the CAT scan of the head to her, and she agreed that she agreed to change his code status to do not resuscitate CC arrests, which means the patient will receive full treatment. Patient will get all kinds of treatment, but in case his heart stops, I'm not going to do any resuscitation and let him go in peace.
Okay, so that's the difference between the DNRCC arrest and the Dnrcc?
Yes, ma'am.
Okay. All right, I'm going to scroll down a little further. I want to talk a little bit about this general area. What does that mean to us?
General area means what is vital signs, when the patient comes to ICU, and so I reviewed all these vital signs. Vital signs means blood pressure, heart rates, oxygenation.
When I look at the I section, what does that mean to us, pupil dilated fixed?
Means really, it could be early because he has a cardiac arrest, and some patient will have this dilated fixed pupils that it can be reactive later on, or he will have, because of his cardiac arrest, he could have severe brain injury, and this is reflected in his pupils with a dilated fixed nature.
All right, and what about the neurological finding?
Yeah, when I have any patient comes as a cardiac arrest, I need to assess him if he has any response to verbal or painful stimuli, and I also assess him to have any coronary reflexes, because these are signs of a brain injury. Okay, so one important factor when any cardiac arrest comes to ICU, I need to see if he has any brain injury or not, because this is the most prognostic factor. And these are all signs I'm looking for in my exam.
And what did you find regarding Mr. Hayes, sir?
He was not responding to any verbal or painful stimuli, and he has no coronary reflexes.
What does that tell you as the doctor?
Tells me he has some sort of brain injury.
And when you say not responding to painful stimuli, what does that mean to us as lay people?
Well, when I try to squeeze his shoulder, he doesn't grimace.
So would I be correct in saying he's not feeling pain at that point?
Objection. Again, asking for.
Yeah, we're getting that close there. Let's rephrase the question.
So what does that mean about Mr. Hayes' ability at this point to feel any pain?
Again, it's the opinion she sees.
Wow. Rephrase the question, okay?
So Dr. Hagris, what does that tell us, not responding to painful stimuli?
Again.
Hold on. This means from my,
Doc,
I'm sorry, should I?
Doc. I got my mic off. Okay, doctor, when you see that in your performance of your duties, what does that mean to you?
This means to me that this patient will have, most likely he has some sort of brain injury.
Okay. All right, and I'm going to scroll down a little bit further. Did you reach a diagnosis?
Yes, I put in my assessment plan, he has a cardiac arrest, most likely due to drug overdose.
And what is your goal with him at this time?
My goal at this time is to just support him, and neurologists should come to see him next day and the CAT scan also showed he has a diffuse brain edema.
And what
So
does that
brain
mean?
edema, yeah, means it's a diffuse brain swelling, and this is a one of the poor signs when a patient of cardiac arrest comes to a hospital. Means because our brain cells cannot sustain more than 5 minutes or 10 minutes max without a good blood perfusion. After this, the brain cells will die and will swell, will cause this brain swelling. And when a patient has a diffuse brain swelling, this is a really poor sign of survival. And so at this point, I was supporting him. He was intubated.
Okay, hold on,
And
Doc.
Hold on a
Hold
second,
on.
Yes.
Dr. Hagris, there's an objection.
Okay.
He's getting across the line. I sustain,
Sure.
let's ask him a new question.
All right, I'm going to move on, Dr. Hagris. I want to go down to page 13 for a second.
Okay.
All right, and I want to direct your attention to, hang on, I got to go up just a little bit, hang on. Doggone. Where was that? All right, I want to talk about this top, and it's labeled order. Can you explain to us what this is?
It's a palliative care consultation. And this is when a patient with cardiac arrest comes, I put an order for palliative care consultation, especially with a poor outcome.
And when you say palliative care consultation, what does that mean you're actually doing?
It's a consultation to the palliative care physician, Dr. Phillips St. Emma, and to come and be involved in the discussion with the family to address the goal of care.
And you place that after the consultation with Mr. Hayes?
Yes, ma'am.
Then I want to go down to page 15 for you for a minute. And again, it's an order, but I'm going down to the bottom one. Tell me about this order, the Dnrcc arrest. Tell me about that, please.
Well, when I talked to his sister and I showed to her the CAT scan finding, she agreed that, this is a poor sign, so I changed his code status I didn't change. I placed an order to make his code status do not resuscitate arrest. And do not resuscitate arrest means he will get a full treatment, but if his heart stops, we let him go in peace.
All right, and why do you place this order in Mr. Hayes's EMR, his electrical medical records?
Because his CAT scan of the head findings, of the diffuse brain edema, most likely he will have anoxic brain injury, means that he has more than 10 minutes deprivation of blood supply to his brain, and he will have a poor outcome. So in this case, it's not really recommended to do resuscitation again if his heart stops. So for this, I put this order in.
All right, and when you leave for the night, I should say, not the day, does this notify every other person who's involved with him that this is what his code status is?
Yes, ma'am.
All right, I am going to switch to what I've labeled as 3B regarding Beverly Schertzinger, and let me get to that record, sir. All right, and I'm going to go down, all right, and before I go anywhere, can you tell us which patient this is regarding? Hang on, let me share screen, forgot that step. All right, and Dr. Hagros, can you tell us which patient this is regarding?
Yeah, it's Beverly Schertzinger.
And what's her date of birth, sir?
It's October 17th, 1953.
And what is her admit and discharge date, sir?
October 2nd, 2017, and the short date is October 9th, 2017.
All right, and I'm going to go down to page 20 for your sake to get through to where you're at. All right. And can you tell us what you're doing at this point with Ms. Schertzinger?
Most likely she came on my shifts, and I was a critical care consulting physician, and I saw her when she came to ICU.
All right, and I'm going to scroll down for you. Can you tell us why she came into ICU?
She is 63-year-old lady. She came to ICU because she has some productive cough, and her PCP, she visited her PCP, but nothing been done. So she came to our Grove City ER, and they perform a CAT scan for chest, and they showed she has a cancer, most likely a cancer in her left lung, and she was. This is why she came to ICU. Her sodium was low. Her sodium hyponatremic. Hyponatremic means her sodium was low, and per our hospital policy, if any sodium less than 120 has to come to ICU, because these patients are prone to have seizures.
Okay.
So she came to us, to ICU.
All right. I'm going to go down a little bit. And just kind of following along the same thing we did with Mr. Hayes, tell us about her general condition that you looked at that time.
My exam for her was general. She was reviewed all her vital signs. Her eyes were fine, mouth was fine, respiration was fine, cardiovascular was fine, GI was fine, neuro was fine. So yeah, so her exam was benign. Yeah.
Did you give her a diagnosis at that time?
Yes, her main diagnosis that brought her to ICU is acute hyponatremia, mean acute low sodium.
Okay. And what were you looking at as far as treatment at that point when she's in the ICU with you?
My main goal is to bring up her sodium to the safe range. So because of her new diagnosis of lung cancer or lung mass, so this is a condition called SIDH that cause low sodium. For this, I needed to restrict her fluids to bring up her sodium and follow blood work every 6 hours. And in the same time, I wanted to work up her cancer to see if it is spread anywhere else. So I sent her for other CAT scan of her head, abdomen, and pelvis. And I consulted oncology team to follow on that.
All right. And I'm going to go forward to page 53. And I just want to talk very briefly about this order. Can you tell us what was ordered at this time for Ms. Schertzinger?
This order for severe pain, it's as needed order, and I order morphine 2 milligram IV push every 2 hours for severe pain scale. Yeah.
And IV push, what does that mean to us?
IV push means like it's a syringe, like maybe 10 cc or 5 cc syringe, and the nurse will, like, will get it from the vial and push it to the patient when patient requires pain control.
And do you remember, while you were treating Ms. Schertzinger, did those 2 milligrams help her pain?
No, I don't remember.
Okay, that's fair. All right. I'm going to switch to Mr. James Allen. Just a minute. There we go. And this is what I've marked for identification as State's Exhibit 8B. Dr. Haggard, can you identify the patient for us?
James G. Allen, his date of birth is 5/29/37.
And what was his admit and discharge date, sir?
He was admitted on May 24th, 2018. The discharge date is May 28th, 2018.
All right, and I'm going to go forward to page 5 and 6. Dr. Hagris, can you tell us what you're doing here? What is your involvement with Mr. Allen?
I was putting a vascular access. It's either a central line, it's a long IV access, go to the one of our main veins, and this will give us a good access to give him all kinds of medications. At the same time, if I need any blood work, or we can just take it from this line. Or I was putting an arterial line. Arterial line, it goes to one of our arteries here in the hand to just monitor his hemodynamics.
Okay.
So it's not clear here in this page which procedure I placed for him.
All right, let me go down and see if that clears it up.
Okay, so it's a central line.
Okay.
It's a central venous line, yes. So I placed a central venous line in the right internal jugular vein.
Any issues with that procedure?
No.
And what was Mr. Allen's diagnosis that he was in the ICU for at this point?
I can't tell from this document really. But here, it's here. Diagnostic shock, yes, here. Septic shock. Septic shock means patient has severe infection that caused him to have a low blood pressure.
Okay.
In this case, the patient will need antibiotics, we need a medication to bring up his blood pressure. And in this case, I need to place a central line to infuse safely these medication.
Okay. All right, and I'm going to switch now to Sandra Castle.
She's Sandra M. Castle, okay.
And what was her admit and discharge date, sir?
Admit was November 10th, 2018. Discharge date is November 13th, 2018.
All right, and I'm going to advance to page 7 for you. And can you tell us what your involvement with Ms. Castle is at this point?
I think I'm the one that I admitted her to ICU, or I saw her when she came to ICU, and I put the critical care consultation.
Okay. And why was she in the ICU with you?
She came because her husband found her unresponsive, and I'm sorry,
Sorry, I
could
went
you
past
scroll
it.
up a little? Yeah. And okay, and she has a cardiac arrest, and her son started the CPR. EMS was called, and they took over, and she was in BFib arrest. So she was in cardiac arrest, and she got shocked by EMS, and they give her a medication called amiodarone, and she got intubated, and her pulse came back, and they started her on a pressor medication, Levofit. When she came to ICU, she was moving, but not purposeful. And I cooled her down in the ICU, and I did talk to her family in the waiting area and updated them about the plan of care.
Okay. And along the same lines as we've talked about with your other consultations, what did you find as far as her general vitals?
Well, I reviewed all her vital signs when she came to ICU, and her pupils were reactive, and I didn't see anything in her mouth or respiration. Could you scroll down, please? Yeah.
Yes.
Otherwise, yeah, I didn't see any abnormal cardiovascular or, yeah.
And what was her general condition then as she was admitted to the ICU?
She was critical, in very critical condition.
Okay. I want to talk about, you indicated she was intubated. What does that mean to us?
This means the patient cannot maintain her own breathing. So she got a tube down her throat, and she's hooked to a ventilator to do the work for her.
Okay. And I note here you actually use Versed and fentanyl together. Why would you use that medication at this point?
This is a very common practice to start this medication while the patient is intubated, because the tube itself is irritant, okay? So, and it will cause a gag and cough. So I need to keep the patient comfortable, and I want the patient to work with the machine. For this, he has to be under sedation.
Okay. And I'm going to go forward to page 73 first. And Dr. Husel, I want to talk about this order here, full resuscitation. What does that mean to us? Dr.
By the way, I'm
Haggis.
Dr. Haggis. Yes.
Sorry.
Yeah. Yeah. So full resuscitation means it's a full treatment. Patient will get a full treatment, and if his heart stops, I'm going to do a resuscitation, give him all kind of medication to bring him back.
Okay. And going forward a little bit further to some of your your orders. Dr. Hagris, I want to talk about this order here for fentanyl. Can you tell us about how much fentanyl and why you're ordering it at this point?
This is because she's intubated, so I need to keep her under sedation. So if she needs a breakthrough pain control, I'm providing her with 50 mic of IV push every 1 hour as needed.
Okay, so,
And the RAS score at this point was -1 to +1.
all right, so tell me what a RAS score is, because we haven't heard that
It's
one
called
before.
it's a Richmond agitation sedation score, and it goes up to +3 to -5, and this score like mainly we keep the patient +1 to -1, and this score the nurse will render every maybe 1 hour to be sure the patient will meet the score. And this score, what's the goal is just to keep the patient comfortable and synchronous with the vent, because I want the ventilator to work for the patient. So I want him to be on this like sweet spot, so he will be comfortable and the ventilator will work for him.
All right, and you ordered 50 micrograms IV push inject. Tell me how that's going to be administered so we understand this.
Well, I put the order in. The order will go to the pharmacy to verify it, and they will send it to the nurse. The nurse will get the vial, will take the medication and push it to the patient if the RAS score is still not maintained.
And this was something that would maintain them, is what you said, as far as patient, while they're on the ventilator?
Yes, ma'am. Yeah.
Going on to the next page in this order. Fentanyl additive, 2,000 micrograms. Can you explain what that is to us?
This is an infusion medicine, and this is also a common practice. In my practice is a patient has a tube down his throat, he's intubated. I want to keep him in a good rest score, so support him. So I will start fentanyl infusion to be sure the rest score will be maintained like 24 hours. So I start him on I start her on fentanyl infusion. The range is 25 to 500 mics per hour. So they start 25 and they titrate up to achieve the RAS score. And the RAS score is the same here, -1 to +1.
25 to 500 an hour, so that's going to be for an entire hour time period?
Yes, ma'am. 25, we start 25, and the maximum is 500 mics per hour.
Is 500 mics per hour high?
Objection.
Sustained.
Okay. What would determine how much fentanyl that Ms. Castle will get each hour?
I'm sorry, say it again, repeat it, please.
No, it's not the same thing. Doctor, when you made this
Yes.
order, okay,
I'm sorry, I can't hear. Can you?
I've got my mic off because of the echo. When you made this order, why did you put that amount of fentanyl to be distributed to her?
Well, it depends. We start 25 mics per hour. Then the nurse will assess the RAS score. And you can see here, it's a titration, titration medicine. So she will titrate up till she gets the RAS score -1 to +1. And this is where the patient will stay on.
Right. All right, Dr. Hagris, here, let's talk about this order also.
This is also a common practice is to start a sedation. So the patient, when the patient comes, like, a critical ill patient, and he's intubated or she's intubated, I need to keep the patient on 2 infusion medicine on analgesia and sedation. So analgesia will be provided with a fentanyl, and the sedation will be provided with Versed. Plus, I'm cooling the patient down. I'm putting the patient under a cooling blanket to bring down her temperature, and this is very discomforting. So I need to be sure that she gets enough sedation. So I started Versed infusion, which is 50 milligram on the bag of normoxidine. It's a 2 milligram per hour, and the RASS score is the same, -1 to +1.
So did I hear correctly, 2 milligrams per hour?
Yes, ma'am. Yeah.
All right.
Yes.
And you had just said this is very common when they're intubated. Can you explain that to me?
When patient is intubated, I need the patient to be in a good, comfortable, spot, and the machine will work for him. Plus, this patient also, I cooled this patient down. So her temperature, I'm going to drop her temperature to 34 Celsius. So, and this is very discomforting. So, I need to keep her under good sedation. So she will not shiver. She will not really be agitated. So, and this is a common practice in these cases. Yeah.
All right, and you said something that, you said because the ventilator will work for her. What do you mean by that?
Well, I need to be sure the patient will be synchronous with the vents, because sometimes when the patient is not under enough sedation, the patient will cough, the patient will fight the vent, and the vent will keep alarming. So in this case, this means the patient needs more sedation. So in these cases, I need to keep the patient under enough sedation so the vent will work for the patient till I fix the problem in the patient.
Okay. All right, and Dr. Hagris, I'd like to talk to you about this order from midazolam, Versed. Can you tell us about this?
Yeah, this is for the breakthrough agitation, like the breakthrough pain for fentanyl. I put a Versed, it's a 2 milligram injection every 15 minutes if the patient needs it, and to get the RASS score, under control. But this is mainly, this is not mainly for the RASS score, this is mainly for agitation,
Okay, explain that to me.
A patient gets agitated and she is coughing, she is fighting the vent. In these cases, we give this medication to keep the patient synchronous with the vents.
Okay, and here you're using 2 milligrams, I'm sorry?
2 milligram IV every 15 minutes, yes.
Okay. All right, and I want to switch over then to the last patient you were involved with, which would be Rebecca Walls. And Dr. Hagris, can you tell us who these records are regarding which patient?
That's Rebecca A. Walls, and her date of birth is July 7th, 1943. She was admitted on November 13th, 2018, and discharged on November 19th, 2018.
All right, I'm gonna move down. To page 2 here. Can you tell us what your involvement with is with Ms. Walls at this point?
She came to ICU in my shifts, and I saw her ICU and put the critical care consultation.
And why was she coming to see you at the ICU at this point, sir?
She came to ICU, she had a cardiac catheterization, and she had a complication with a groin hematoma. Patient was in PACU for 15 minutes with the pressure applied to the groin to stop the bleeding. And she came to ICU because her blood pressure dropped and she became altered. But in ICU, she was more arousable. She gave me all her answers, and I found also her carbon dioxide was high, so I placed her on BiPAP, and vascular team was consulted stat because of her because of a groin hematoma.
All right, hematoma, what is that to us lay people?
It's a blood collection under the skin.
And BiPAP, what is that?
BiPAP, it's a pressure mask. Okay, it applies two kind of pressure. It's something like when, sleep apnea, when patients sleep on a CPAP machine. This is like this, it's a pressure mask, provide pressure and oxygen for the patient.
And as we've talked about with the others, what was her general condition then at that point in regards to her vitals?
Well, in my exam, I reviewed her vital signs. Everything seems to be normal except her extensive right groin hematoma, and it went down to it extended to her midline of her right leg. Otherwise, she was alert, oriented, time 3, yeah. So everything was benign except her right groin.
Okay. And as far as any other information that would be relevant or that you found relevant at that time?
No, CT or I sent it for.
Okay,
Object. Hold on, Dr. Hagris.
so the question
Okay.
is okay, but clearly you need to, let's rephrase the question.
Sure, absolutely, sir. Her general condition at that time, other than what you've told us, was there anything else that was important to you as the treating physician at that point?
Well, at this point, I wanted to send her for CAT scan, just to be sure there's no bleeding in her abdomen, like behind, like something called retroperitoneal. It's a part of our abdomen. And at the same time, her pressure was still low. So I started her on IV pressor medication called Levofed. And I placed a central line for her, and I give her 1 unit of blood. So she was in fairly critical condition because she was in Levofed. She required blood transfusion, and I was looking for the CAT scan finding also. Yeah.
All right, and you've said the term pressors a few times. What is that to us?
Pressor, it's a medication when the patient has a low blood pressure. This medicine, what it does, it constricts our artery to bring up the blood pressure.
Okay.
The main agent that we use in ICU called Levofed, which is a norepinephrine.
Okay. And I'm going to go forward to page 67. Okay, and in case, I don't know that I said this for the record, this is what's labeled States Exhibit 13C. I want to direct your attention at this time to the order in the middle of the page there, midazolam. Can you tell us about that?
I order Versed midazolam. It's not clear here how many milligram.
Okay.
It's IV push, but for some reason it doesn't tell us how many milligram was the order.
Okay, let me go forward then and see if we can get anything else. All right, so let's talk about the fentanyl. Can you tell us about that?
Yeah, I order here it's a 50 mic, but it doesn't specify how frequent. Is it one time or what? It's not clear in this order, but I order 50 microgram of fentanyl.
Hang on just a second, Dr. Hagris. Maybe I can simplify this. Just a minute, Dr. Hagris.
Sure, take your time.
All right, just a few follow-up questions, Dr. Hagris. You'd indicated your shift. What days did you work at Mount Carmel West?
What days?
Correct. Or nights, I'm sorry.
One night. So I work, me and Houston, we used to split the week. So I come and I work 4 nights. Then he will come to cover 3 nights. Then the week after, I come and cover 3 nights, and he will do 4 nights.
Okay. And were there specific nights you worked as far as days of the week, nights of the week?
Yeah, I remember I had specific nights, but I really don't, I don't remember the exact dates right now. I remember that we were alternating Saturday nights.
Okay.
But I don't remember, yeah.
Okay, that's fair. When you were describing the BiPAP, you referred to CPAP. What is CPAP to us? CPAP,
CPAP is a machine. Patient has sleep apnea. He sleeps on to keep the pressure on oxygen. But the BiPAP is more, it gives more pressure. It gives 2 pressure. And this is what we use in the hospital.
Okay. Do you know what the CPOT is? CPOT.
Well, it's a pain scale, but it's more nursing business. You know, I don't use it really.
Okay. Dr. Hagris, we've seen how you've used the fentanyl over the course of, I think you called it titration, so many micrograms per hour, depending on the score. The RAS score was how you had it in those. Have you ever given one?
Okay, there's an objection, it's premature, overruled for now. Finish the question.
1,000 micrograms of fentanyl as an IV push? And wait a second before you answer that.
Okay, overruled. You
Okay.
can answer that question.
You can answer that question, Dr. Hagris.
No, ma'am, I did not.
Okay. No further questions, Your Honor. Dr. Hagris, we're going to have to do some logistics and switch the computers out so Mr.
Okay.
Baez can ask questions, so hang on a minute, okay?
Can I do my job?
I'm sorry, sir.
Okay. I need to give my court reporter a break. We've been going at it an hour and a half. Okay, so we're gonna take 15 minutes. We'll get all organized. You can stretch your legs, walk around. get comfortable, get a
Okay.
cup of coffee, whatever you want, and then we'll be back
15
in
minutes?
15 minutes. Ladies and gentlemen, I'm gonna
Thanks, sir.
send you on break for 15.
All rise.
Remember the admonitions.
I'm gonna leave them all here.
Hopefully we don't lose the contact, because he just shut us off. Is there anything for the record, Ms. Swanson? Anything for the record? Well, let the jurors get out here first. Anything for the record?
No, Your Honor.
Mr. Baez?
Jose, anything for the record?
Okay.
We're gonna figure this
We're
out.
in recess. You guys can get set up. Mr. Kirschman, do you need to see me? No, Judge, okay.
Do you
Yes, sir.
guys have the Zoom link? That's probably where we have to start.
Sawyer, I know.
Yes.
I
All right,
got it
hang on a
right
second. Let me
early.
Get into my email.
I apologize. I don't know why I want to call you Swanson.
That's okay. I think I worked at Stark County for 7 years, and about my 4th year in, somebody called and said, "Is there an S on the end of your last name?" I'm like, "It took you 4 years." All right, let me find the Zoom link. Oh, awesome. All right, well, that's not going to help me when I go. Let's see what I can do here. Forward. We're working on it. Okay. Yeah.
I need to set up my coaster.
Hey, Taylor, can you that, I can't forward a forward. Can you send the Zoom link over to Allison? All right, yeah, that's my problem. I can't forward a forward, so it's gotta come from, you have the original link, it's gotta come from you.
Yeah, well, I think there's some, but I think there's some.
There are actually 40 screens going on.
Please
Yes, sir.
report.
Yes, sir.
Prosecutor. Good morning, ladies and gentlemen. Good morning, Dr. Hagris. Or shall I say good
Good
evening?
morning. Well, good evening, you're right, good evening.
All
For
right.
me.
Well, okay. Well, good evening to you, sir. I'm going to try and go chronologically on a few things. And this is my first time doing something like this, so please bear with me, okay?
Sure.
Okay, you testified that your first day of working at Mount Carmel, you were given a couple of hours of orientation, is that correct?
3-4 hours, yeah, I don't remember exactly, but yeah, few hours, yeah.
Now, after that, you then had a small IT session, correct?
Small what?
IT, like a technical session about how the
Oh, yeah,
system works.
yeah. I think it was before that I had an IT in the physician lounge. I think it's like for also a few hours with other physician. But before my IC orientation, I had, I had the IT orientation.
Okay, and Dr. Hagris, it was the Mount Carmel job, your first job out of medical school?
No, sir. I did 3 years and a half in Atrium Medical Center. I was inpatient hospitalist. Then I was promoted to be a medical director of the hospitalist group in Atrium Medical Center. Then I came to Mount Carmel.
Okay, so you had prior work experience after having your residency and all of your other training, correct?
I had what?
Other hospital experience.
Yes, yes, sir.
Okay.
Yes.
And after,
Mr. Baez, you're getting away from the mic,
Sure.
and that's what's part of this problem.
okay, can you hear me okay here?
Yes,
Okay.
that's perfect.
If you can't hear me, please just raise your hand and I'll make sure I adjust. So, sir, after, I guess, these few hours of training, you were then placed to work in the evening shift at Mount Carmel, correct?
Correct.
And you're the only doctor there in charge of 30 beds, is that correct?
Yes.
Okay. But you work with a big team. Wouldn't that be fair to say?
Yeah, I used to have a resident in the beginning. I think in the first 4 years, I used to have a resident work with me overnight. And of course, I have the charge nurse and the nurses.
Okay, and the residence is basically a doctor in training, right?
Yes.
Okay, so you're kind of training this doctor on how to do things.
Yes, yeah. I was his, like, backup, if he needs anything, if he has any questions, if he wants me to supervise any procedure, I will be his attending doctor.
But as far as the medical decisions to be made, the buck stopped with you as it related to these 30 beds when you're on your shift, right?
Well, if the residents, like, there used to be two kind of patients come to ICU. A patient with insurance will go to a hospitalist, CIC, and this is where I will manage this patient. And patient without insurance will go to a mid-clinic resident, and he will make decisions. And if he has any questions, he will come to me. But also he was in the capacity to make decisions for these patients.
Okay, and when you said that was at the very beginning of your employment. Was that before Dr. Husel was working there?
Yes, was before he came. He came August, and when I came, there was a resident always overnight, and this resident overnight stayed, I think, for the first 4 years of my employment.
And And Dr. Hagris, you had different training. Your specialty was internal medicine, correct?
Correct.
So that would make you an internist?
Internist, yes. Hospitalist, yes.
And that is different than Dr. Husel's training, correct?
Dr. Husel, he has a fellowship in anesthesia critical care. So he got internal medicine, then he went to fellowship. So it's different, yeah.
And you're aware that Dr. Husel was trained in anesthesiology, correct?
Correct.
Okay. So those are two completely different fields, right?
Not entirely, because the anesthesia, like in the anesthesia also, they will have internal medicine training, because to apply the anesthesia, you have to understand the physiology and pathology and all kind of like diseases, so they can apply the anesthesia science. So it's related, but it's not different, no.
Well, I'm not saying that they don't overlap. What I'm saying
Yes.
is that they're completely different. So for example,
Objection, Your Honor, he's testifying.
I was about to ask it.
Well, I'll let you have the question. Go ahead.
So for example, an anesthesiologist has more training in the areas of sedation, correct?
Yes, in the OR, yes.
Okay.
It's
A-
most
and-
likely in the OR.
Okay, and that would involve drugs such as fentanyl.
Correct.
And it's fair to say that an anesthesiologist is more comfortable and has more experience working with a drug like fentanyl.
Okay.
Objection, Your
But
Honor.
in,
Sustained. Let's do a little sidebar if you want.
I'm sorry, should I answer or not?
no,
You
hold
can't
on.
answer it. You want to do a sidebar?
Sure,
I know you're
sure.
dying to talk to me.
So taking apart the overlap, in medicine, there are different types of specialization. You would agree with that, correct?
Yes,
And your specialization is that of internal medicine, right?
correct.
And can you describe for us the differences between an anesthesiologist and that of a internist?
Well, internal medicine, it's a 3 year program that's it's specialized in every organ. Like, you know, I had like 6 rotations of ICU in University of Maryland East Campus. I had a cardiac rotation. I had a GI rotation, neurology rotation, rheumatology rotation. So all kind of like, you know, like topics in internal medicine. I had a rotation. Also outpatient had rotation. And I had to have a board test to be board certified in internal medicine. Anesthesia, I had like, you know, of course, interaction with anesthesiologists in my training, also in my work experience. So anesthesia, they are specialized in the operating room where they put the patient that he will go to surgery under sedation. They work with different kinds of medication. They work with the surgical teams in different fields. And they also responsible for waking up the patient after surgery. And they are also responsible for the ventilator management during the surgery.
Okay, so to try and put this in simpler form, in a simpler form, and I don't want to, if I'm incorrect, please correct me, but to try and put this in a simpler form, an anesthesiologist is trained or has specialized training in management of pain, is that correct?
No, I mean, like, we need to add first, it's OR.
Okay.
I need just to be sure. It's in the anesthesia this is my understanding, and this is what I have seen in anesthesiologists. They work mainly in the operating room with the surgical patients, managing different kind of medication plus ventilator management.
Okay, so they're not the ones actually doing the surgery. They're the ones there managing the medications while the surgery is going on, correct?
Correct. They are managing the sedation for patients, yeah.
Okay. And there's a whole area of specialization dealing specifically with that area of medicine, right? And that's called anesthesiology.
I'm sorry, could you rephrase the question?
Sure,
Because
sure. So there's a whole area of medicine called anesthesiology that specializes in that type of pain management, correct?
Well, see, you keep pressing on pain management. You see, anesthesia, it's not about pain management. This is my understanding. Pain management, there's a different fellowship for pain management. There is a different fellowship called palliative care for pain management. Anesthesia is primarily to manage the surgical patients in the operating room to keep the patient under sedation while the surgery is done and managing the ventilator. I have no knowledge that the anesthesia is connected to pain management. This connection, I'm not aware about this.
Okay, I think it was a poorly asked question because I didn't want to imply that it was limited to that. There's obviously other areas that an anesthesiologist does. Let me try this. Fair to say, Dr. Hagris, that equally trained doctors with the same exact backgrounds can have difference of opinions on various aspects of medicine, correct?
Yes.
Okay, and in fact, that's why many people get second opinions when it comes to doctors, right?
Correct.
because one doctor may be more comfortable doing things one way, and another doctor may be comfortable doing things another way, correct?
Correct.
Now, in light of that, and then that also takes into consideration what we as lay people may be considering a good doctor versus someone that's not as skilled.
Objection.
I'll permit the question.
You can answer.
Do you understand the question?
Yes, I understand. Yeah. Well, it's in medical field, you know, as you said, you know, every doctor has its own, like, you know, comfortable, like, you know, level and comfortable medication that you use. And judging doctor by doctor, this is like, I don't think, you know, this is fair.
And you don't think it's fair because each doctor's experiences are also different, right?
Yes.
Okay. And that's because so much of medicine is patient-specific, right?
Yes.
Now, in light of that, Dr. Hagris, when you got trained at Mount Carmel when you first started, were you trained in anything that goes on at the pharmacy?
Goes to what? Pharmacy?
Yes. Were you trained in anything having to do with the pharmacy?
No, sir. No.
Okay. Were you trained as to every single thing that a nurse does at Mount Carmel?
No.
Were you trained on the Pyxis machine?
No.
Did you have access to the Pyxis machine?
No.
So could you ever go up to the Pyxis machine and put your fingerprint there and it would open up a drawer?
Well, I never tried. I never tried, so I think it won't work, you know. No.
Okay.
Because the only two people, I'm sorry, the only two people I have seen going to the Pyxis and get medication or put medication in is the nurses and pharmacists.
Okay. So when you, fair to say you had the same exact position as Dr. Husel, correct?
Yes, sir.
Okay. Now, you just work different nights, right?
Yes.
Okay. So, in light of this, you're familiar with how things work at Mount Carmel, correct? In the ICU.
Yes.
Okay. Now, having said that, when it relates to medications, you either give a verbal order or enter in a written order, correct?
Correct.
And as far as you know, the medication gets administered, right?
Yes.
And that essentially is the end of your involvement, unless it needs to be addressed later, correct?
Not really. I mean, it's like if I give any medicine, like for example, if a patient has high blood pressure and I order blood pressure medicine IV, and and I give this medicine, I put it in, I will follow up with the nurse to be sure the goal is achieved. You know.
I meant.
So there's some follow up.
I apologize for the poorly asked question. I meant as far as it getting administered. So.
Oh yeah, that's it.
That's it, right?
Yes.
So, for example, you give as a doctor a order to a nurse. That nurse will either input the order if you didn't do it yourself, and then at that point, as it relates to up until the point where it gets given to the patient, you have no further involvement, right?
Correct.
Now, as far as you're aware, at this stage, if it's a medication, at this stage, it goes to pharmacy for approval, correct?
Yes.
Okay, and if pharmacy approves it, you have no idea. All you know is it gets administered, correct?
Yes.
Now, if you see that it's administered, is it your belief that pharmacy approved it?
Yes. In my practice, yes.
Okay. If it's not administered, and what would happen? If it's not, let me rephrase it, that's a poorly asked question. If it's rejected by the pharmacist, how are you made aware of this?
Well, the pharmacist will call me to ask me, like, for example, if I bought an antibiotics and a patient has a kidney failure and the antibiotic dosage should be adjusted. So the pharmacist will call me and he will say, I need to adjust this. Are you okay with that? And I said, okay, do it please, and put it under my name. And he will put it under my name and he will adjust the dose and he will send it to the nurse.
So I'm clear, so we're all clear. The only way you're ever notified if there's an issue with your dosage
Okay, you're away from the mic.
is if the pharmacy comes to you and talks to you, correct?
Well, he will call me. Most likely he will call me on my hospital phone and he will talk to me, yes.
Okay. Now, in addition to that, but prior to going to pharmacy, if a nurse has an issue with your dose, he or she can also bring that to your attention, correct?
A nurse? Well, in my practice, I don't recall a nurse came to me and told me that I'm not comfortable with this dose. But they have the capacity to do that, but I didn't have this experience.
That's what I'm asking. I'm speaking in general terms here. It's your understanding, sir, that the nurses, they're not just robots, right? They have their own independent medical judgment, correct?
Correct.
And
Correct.
that's a part of the process, right?
Yes.
So if a nurse took issue with any of your doses, they have the ability to, and it's your understanding, they have a duty to speak up, right?
Correct.
And at that point, the only way you're advised, if a nurse has an issue with any of your orders, is if she either speaks to you about it, correct?
Yes.
Or perhaps she goes to a manager, like a nurse manager or the charge nurse, and they speak to you about it, correct?
Yes.
And in fact, there are multiple ways that these things can be done, correct? And let me give you a couple of examples before you answer. One, they can speak to you directly. Two, they can go to the charge nurse. Three, they can go to the nurse manager. All of those are correct, right?
You just asked that.
Yes.
I was summing them up, Judge. And in addition to that, you talked about a voice report earlier in your direct examination, correct?
Yes.
That's
Yes.
another way you could discover whether someone has an issue with your doses, correct?
Yes, sir.
Okay. Are you ever notified any other way other than the pharmacist calling you that an order has been rejected by the pharmacy?
No, I mean, this is the only way, and the term rejected really, it's not clear in my ears, because I never had this before, but yeah, the pharmacists always call me. They always call me if they have any, like drug interaction. If they have any concern about anything, they will call me immediately.
And that's something as a doctor that you rely on, right? If there's some kind of drug interaction or an issue with the drug, that the pharmacist will tell you about it, right?
Yes, yes, sir.
Okay? And you rely on that daily for your job.
I'm sorry, could you get close to the mic?
Sure. And you rely on that daily for your job, to do your job correctly?
Yes, yes.
Okay.
Pharmacy is very important, yeah.
Now, are you ever aware whether a medication is prospectively reviewed or retrospectively reviewed by the pharmacy?
In my practice, no.
Nobody comes and tells you this was prospectively reviewed, do they?
No, sir.
Nobody ever comes to tell you this is retrospectively reviewed, correct?
Correct.
And nobody ever comes to you and says this was simultaneously reviewed at the same time as it was administered.
No, sir. The only thing I get from the pharmacy, as I said, when I put the order and there's some, concern about dosage, antibiotic, kidney function, anything, they will call me and we'll discuss and we will adjust it and the order will be approved.
And that's not something you go actively looking to find out, is it?
Say it again, what do you mean?
Whether something is prospectively reviewed or retrospectively reviewed, that's not something that you go actively looking to find out, right?
No, I don't know even, it never happened in my practice, so I don't know how even to look for it yet.
Okay, you wouldn't know where to look and know that, right?
Yeah,
Okay, and it's not even a factor in your consideration. It's not something you do, right? It's not something you do at all in your job, is I guess the simple way of asking this.
I think there's some misconception right now. So let me clarify. So I put the order in. It's either verbal or in the system by myself. If there's any concern from the pharmacist, he will call me. He will call me and we'll discuss and we'll adjust it and it will go through. That's it. And the medicine will be sent to the nurse and she will give it to the patient. So I never had any in my practice about any of these prospective or respective review. So I have no knowledge about this.
Okay. Now, having said that, sir, you are also not aware, or let me strike that. Do you ever pay attention as to how the nurse actually retrieves the medication? Do you ever get involved in that
No, sir.
process? I'm sorry?
No,
Okay.
no.
Do you ever find out whether the nurse received the medication after it was approved or before it was approved?
Well, in my practice, I put the order in, and the only time that I put the order in after the medication was given in emergency. So a patient has a cardiac arrest, and there's something called a code blue card. We pull it, and we break it, and we give the medication, give it to the patient. And after doing the resuscitation, I go and I ask which medication was given, and I go to the system and I put the epinephrine, atropine, whatever was given to the patient. So this is the only time the pharmacy will approve medication after it was given. But in my practice, all the medication will be ordered by me or the verbal order, approved and given to the patient.
Now, Dr. Hagris, it's also when you don't write in the order and the nurse does it, you have no idea how they enter in the order, do you?
It comes to my inbox. It comes to my inbox as a co-sign order. So I verify the order, then sign it.
Okay, let me see if I can ask this question a little bit better. Are you familiar with the phrase "scan to order"?
Scanned order?
Scan to order.
Yeah, this is a nursing business. I'm not really, I don't have the best knowledge about it.
Right, so let me give you an example of what I'm referring to.
Hmm.
Where's this one? Let's bring up this one first. Now, you recall giving discussions about Rebecca Walls. Do you recall that? I'm showing you at this time what is Exhibit 13, page 343.
Take it out.
Okay.
You gotta enlarge that. You've got just a short screen there.
Yeah.
Expand it out.
Okay.
You can also make the screen, the frame bigger.
That's what I'm trying to do.
Top, middle.
I think it does any bigger than that.
Okay, let's go down to the bottom.
I tried.
Now, well, actually, let's stop here. You would, go back up to the top. Sorry. Okay, you would agree that this is the medication order for Rebecca Walls? Do you see that?
Yes, sir.
Okay, and you were asked about her during direct examination, right?
Yes.
And you were shown various medical records about Rebecca Walls?
Yes.
Okay, now I want to direct your attention to the bottom of the screen, specifically the order for midazolam.
Okay.
Can we
Could you
scroll that
scroll
down?
it down?
Yeah, he's going to scroll down for you, all the way down. There you
Thank
go. Okay. Now, taking a look at this order, this is an order you gave, right?
Yes.
And in this order, the date is November 16th, 2018. Do you see that?
Yes.
And midazolam is a controlled substance? What is it? What is midazolam?
Yes. I'm sorry?
What is midazolam?
It's a benzodiazepine. It's a sedative medicine.
Okay, it's also called Versed, right?
Yes.
Okay, and you gave this order at this specific time, and if we could scroll up a little bit more. No, I'm sorry, scroll down. Okay, and in here, do you see whether pharmacy approved it?
No, I don't see the pharmacy. Do you see? I mean, no.
And do you see if it ever went to pharmacy?
I'm sorry?
You see, does it indicate whether it actually ever went to pharmacy, whether they even saw this medication?
No, this medicine, it's 4 milligram of midazolam. This medicine, when I use it for emergent intubation. So this was an emergency for intubation for Miss Wallace. And for this, it was given and placed and co-signed with me after giving the patient.
I understand that. But my question to you, sir, is on this record, and if you look down at the printed date and time, it was printed out December 6, 2018. Do you see
Yes.
that there? Okay.
Yes.
Do you have any indication by looking at this right now whether it actually ever went to the pharmacy at all?
No, I don't see the pharmacy name in it.
Okay. And if you look at this, you have no knowledge as to whether this controlled substance was ever reviewed at any given time, even after it was administered, correct?
Yeah, I don't see anything in the review information part, yeah.
are you familiar that this is what's called a scan to order?
I'm not sure about this term really. It's kind of like a nursing, but I heard it, but I don't have full knowledge. But I want to clarify this order when I put it in. This means it's emergency intubation.
I understand, Mike, so in light of this, sir, you're not aware
I'm sorry?
of how, I said in light of this, you're not aware of how a nurse actually enters in the order, even in cases of emergencies, right?
Well, I will verify it, yeah, initially I won't, but after I go back to the EMR, it will come to my inbox, and I will see all these orders, and I will verify it, and if I don't feel comfortable with any of these orders, I can reject it. So you can see, I co-sign this, yeah.
I understand, Dr. Hagris. What I'm asking you is about the pharmacy. Here, and correct me if I'm wrong, here you gave an order in an emergency situation, the nurse obtained the medications and gave it, and there is no indication to you whatsoever that the pharmacy ever saw this controlled substance order, correct?
Correct.
Okay. Now, I'd like to show you Exhibit 12, page 325. And I want to draw your attention to the top so we know who we're talking about. This
Sandra
is
Castle?
patient Sandra Castle. Do you see that?
Yes, sir.
And you were asked questions, quite a few questions about her in direct examination, right?
Yes.
And you were shown various medical records about Ms. Castle during direct examination, correct?
Yes.
Okay. Just for curiosity, were you given these records in advance to review before your testimony today?
Yes.
Okay, so the prosecutor told you which records she was going to ask you questions about?
They gave me the information that I got involved, and they advised me to review these records.
Okay, so they asked you to do this before coming today, correct? Or before logging on today, I should say.
We did it, our lawyer and from the hospital, the one that sent it to me, and I had to interview with a prosecutor. And the hospital lawyer sent it these record to me, plus he sent it also the Columbus interview file to me.
That
And
drug
he asked
order
me
that I
to-
just showed you, did they review that with you?
I'm sorry, say it again?
The drug order that I just showed you that did not go to pharmacy, did they review that with you?
I don't think so.
Okay, now I want to show you this one. We already saw that it was Sandra Castle, right? You want to look at that again, or you're comfortable with that?
I'm okay, yeah.
Okay, let's scroll down. I'd like to draw your attention to this order for fentanyl. You are the ordering physician on this one, right?
Correct.
And did you enter the order or a nurse entered it?
I ordered this.
Okay. This was
100
a
mics.
verbal order that was co-signed by you?
Let's see, oh, yes, I can see right now. Yes, yeah, it's a verbal order by Nurse Matt and co-signed later on by me.
Okay. So this nurse, I guess Matthew Mislewiak, I know I just butchered that.
Yes.
Yes. You got it? Okay. Do you show, and obviously fentanyl is a controlled substance, right?
Yes.
Do you show that this was ever reviewed by the pharmacy?
I don't see this in this paper.
Did anyone ever bring to your attention that this order for fentanyl was not reviewed by the pharmacy?
No.
In preparation for your testimony today, did the prosecutors ever bring to your attention that this order for fentanyl was never reviewed by the pharmacy?
Not to my recollection, no. I don't recall that, yeah.
Is it something that you would ever go looking for during the course of your duties as to whether this was approved by the pharmacy?
No. My responsibility is to take care of the patient, put the orders, co-sign my orders, and discuss it, yeah, like, that's it, you know. I don't review anything with the pharmacy after giving the patient medication.
Now, it's your understanding, as a doctor, an ICU doctor employed at Mount Carmel, that the pharmacy is going to review all of the orders for controlled substances that you give, correct?
I have no knowledge how the pharmacy works.
No,
My
I'm
only
not asking you
interaction
that.
with
I'm asking you specifically, it's your understanding that when you give an order for a controlled substance, that it's going to be reviewed by the pharmacy, right?
No, sir, I have no idea about this, you know. I don't have an understanding, I don't have the knowledge that the pharmacy will review everything.
I don't think you're understanding my question. Let me try and rephrase it, because it might be poorly asked. You believe, when you give an order, it's your understanding and belief that when you give an order, that the pharmacy, for a controlled substance like fentanyl, that the pharmacy is going to review it, right? You rely on that.
Your Honor, I'm going to object. He's answered this question.
He has answered the question earlier in your cross.
Earlier, yeah.
Yeah.
Having seen this, sir, does this surprise you that this fentanyl order was not reviewed by the pharmacy?
Well, I need to clarify something. This is not really my knowledge or job to look for a pharmacy reviewed or not reviewed my orders. So you're asking about something it's really not in my experience, not in my knowledge. So I have no comment about this really.
I completely understand, and there's nobody arguing with that here. My question, sir, is does it surprise you that you're ordering controlled substances that are never being reviewed by the pharmacy? Does that come as a surprise to you?
Objection.
Sustained.
He hasn't answered that.
I know he has. It's not about that.
Okay.
It's about our earlier discussion over here.
Understood, understood. Dr. Hagris, okay. I think we get this point. I wanna move on for a couple other things if I can. Dr. Hagris, the prosecutor during direct examination went over a series of questions for you in relations to some of the medications that you ordered in these patients. Do you recall those questions?
Yes, sir.
Okay.
Okay.
And
You got away from the mic. He knows he was trying to get closer,
Sure,
so.
sure. And all of the times that you gave these medications, they were while the patient was alive, correct? And not actively dying, I should say. Correct?
Well, I did a palliative withdrawal, so a patient is actively dying, I already put orders for them. Yeah.
Let me see if I can clear this up. The questions that you were asked about Sandra Castle, they were not during the palliative withdrawal process of this patient, correct?
Correct. Yes,
They
sir.
were earlier in this patient's care, right?
Correct.
Okay. And you would agree palliative care is different than that, that the normal care of while you're trying to keep the patient alive, right?
Sure, yes.
Okay. In fact, you were at this point executing life-saving measures. You're trying to keep them alive. You're trying to make them better, right?
Correct.
Okay, so that is different than when the family decides that they want to withdraw care and take them off of the ventilator, correct?
Correct.
And in fact, it's fair to say that pain management in the living is different than pain management in the dying. Wouldn't you agree with that?
Well, pain management, I don't think it's, pain management, I use it only when the patient is alive, when I'm trying to keep the patient alive. Pain management, I don't think it's been used for in palliative withdrawal. What we use is comfort care. The term that I use in my practice is comfort care in palliative withdrawal.
That's a term you use, but in essence, when you're withdrawing someone from the ventilator, you don't want them in pain, do you?
Yeah, we do. I do a comfort care, but pain management, this term is used in the medical field in a living patient, but not in palliative withdrawal.
So my question, getting back to my original questions, all of the questions that you were asked about your medications as it related to Sandra Castle were not that dealing with palliative
Yes.
withdrawal, right?
Correct. Correct.
Okay. And then in addition to that, Rebecca Walls, the same thing. They were not in the context of palliative withdrawal, right?
Correct.
Okay. And when it dealt with Ryan Hayes, that was not in the context of palliative withdrawal, correct?
Correct.
And when it dealt
Okay,
with,
hold on, Mr. Baez. Ladies and gentlemen of the jury, it's getting to be lunch hour. If we come back at 1, does anybody have an objection to that? We usually go 1:30, but I've got him and I don't know how many time zones away. Would that be fine with you guys?
Yes.
Okay, why don't we break until 1? Okay, you got an hour off.
Okay.
I hope you're not gonna go to bed on me,
No.
okay?
No.
We'll be back in an hour. David?
All rise.
Okay. Okay, so we'll come back at, what time right now in US is?
It's 12 o'clock noon our time.
Okay, so it's 1
So we're
o'clock. We'll
coming
come
back
back
at
at 1 o'clock.
1, so an hour from whatever time you're at now.
Sounds good. Okay,
Okay.
sir. Thank you.
I don't know how many time zones it is. You guys have a great lunch.
Thank you. Thank you.
I figured you were about ready to transition, So-
Judge, I have no problem with it. Thank you.
okay?
Appreciate it.
Anything for the record?
I didn't even know what time it was.
Miss Sawyer, anything for the record? Anything for the record?
Nothing.
Okay, we're down.
Thank you.
I saw Miss Roberts in the back, did she go? Yeah?
Hey, Dave, come to
I
lunch.
figured she was here to yell at me.
Let's do lunch together.